Hi everyone, my name is Sylwia Kaeding. I will be giving your talk on obesity management. Our objectives for today are to review the options for pharmacotherapy and surgical management of obesity, highlighting the risks and benefits for these strategies. We'll be identifying who are good bariatric surgery candidates and non-candidates, and we will be also highlighting the post-operative follow-up for our patients who do decide to undergo bariatric surgery. Now, obesity, as we know, is a chronic medical condition. We have multiple tools in our toolkit to treat obesity. The mainstays will be nutrition therapy, physical activity, behavioral modifications, and our medical interventions. The scope of this talk will be on the medical interventions through medications and surgical procedures. Now, when it comes to thinking who will benefit from what strategy, for any individual with weight considerations, they will benefit from counseling that hits on nutrition, physical activity, and behavioral optimization. Next, when you're thinking about pharmacotherapy, that will be more related with BMI and comorbidity considerations. So when your patient has BMI from 27 to just shy of 30 and weight-related comorbidities, you should consider pharmacotherapy. Pharmacotherapy should be considered for patients with BMI 30 and above, regardless of comorbidities. Bariatric surgery guidelines are varied, but generally for patients with a BMI of 35 to just shy of 40 and they have comorbidities, it will be recommended. And then if the BMI is 40 and above, regardless of presence of comorbidities, it should be considered. So now to talk a little bit more in depth on the bariatric surgery procedures, the scope of this talk will be on the two most commonly performed bariatric surgeries, the first being the sleeve gastrectomy. This picture highlights very well how in this type of surgery the greater curvature of the stomach is permanently removed and therefore creating what is seen here as a much smaller stomach pouch. It's about the size and shape of a medium banana because there is no part of the stomach that or intestine that's bypassed. There is very little malabsorption. Your food pathway is essentially the same. With this surgery, the ghrelin levels decrease, so hunger will then also decrease. With this surgery, approximately takes 1 hour, and hospital stay can be generally between 1 to 2 days for individuals. The more involved procedure is shown here on the right. It is called the Roux-en-Y gastric bypass, and in this type of procedure, as you can see here, we do create a bypass where there is a smaller limb to the intestine created here. It's usually done laparoscopically. The surgery takes longer, about 2 hours, and the hospital stay is generally between 1 to 3 days. Now I want to go over the pros and cons to each of these different surgical options. The Roux-en-Y, it does lead to greater improvement in metabolic disease and acid reflux. However, because of the bypass nature of this surgery, there is an increased risk of malabsorption complications, more so than is seen with the sleeve. The expected weight loss is very robust. At the 2-year mark, patients are approximately can see a 60 to 75 excess body weight loss. When it comes to total body weight loss, the averages are between 30 and 40%. This surgical procedure is optimal for those with higher BMIs, acid reflux, and type 2 diabetes. Now, to delve into the sleeve gastrectomy, it's beneficial in that it improves metabolic disease and it doesn't have the same degree of micronutrient deficiencies arising. However, it can worsen acid reflux and Barrett's esophagus. The expected weight loss is lesser. So at the 3-year mark, we see 50 to 70% excess body weight loss. When it comes to total body weight loss, that is 25 to 35%. It is optimally suited for patients with metabolic disease. Now, when would you advise against bariatric surgery? The big picture is any type of condition that would make surgery or anesthesia unsafe. These tend to be patients with medical conditions that include end-stage lung disease, portal hypertension, or coagulopathy. You'd want to also consider a patient with inflammatory bowel disease, an untreated gastric ulcer, or GI motility disorders as not being good candidates for bariatric surgery. The pregnancy considerations are very important to note, specifically when a patient undergoes bariatric surgery. Pregnancy should be delayed for a bare minimum at least 1 year to make sure that we're optimizing weight loss and having a stable nutritional status. So if your patient's planning pregnancy, they would not be a good bariatric surgery candidate. If a patient is dependent on tobacco, alcohol, or drugs, they are not a good candidate. If they have uncontrolled depression, psychosis, or eating disorders, they are not a good candidate. And if they are unable to commit to lifelong lifestyle changes following bariatric surgery, they are not a good candidate. The surgical preparation is very intensive, and it does ask a lot of our patients to follow a very, very rigorous diet afterwards. So you would want to make sure that they're able to commit to that kind of lifestyle-based change. After a patient undergoes bariatric surgery, they will need very close follow-up. Specifically, we want to make sure that there are no complications that result. As we know, with the potential malabsorption, we want to be mindful to make sure that there's not any nutritional deficiencies that arise. So some of the vitamins and minerals that we're mindful of with the Roux-en-Y and sleeve are seen in the table below. The vitamins include thiamine, vitamin B1, folate or vitamin B9, B12, D, and then for mineral considerations related to calcium and iron. And it's important that we're keeping a close eye on the vitamin D status, because if a patient is deficient, they may develop osteopenia or a secondary hyperparathyroidism. Now to switch gears and talk about the pharmacological treatment options. These come in oral and also injectable forms. Our oral options are phentermine, phentermine topiramate, orlistat, naltrexone bupropion. For our injectable options, these are in the family called the GLP-1 receptor agonists. You may recognize these as a common treatment option in the management of type 2 diabetes mellitus. Our GLP-1 injectables are liraglutide, semaglutide, and tirzepatide for weight loss. So given that there's so many options for medications for obesity, how do you know which one to select? So first and foremost, be mindful of contraindications. We do not use medications if a patient is pregnant. Keep in mind the patient comorbidities. Ideally, we would be selecting an agent that can potentially address multiple conditions. One example of this would be if a patient has migraine headaches, maybe then you'd consider a phentermine topiramate combination, knowing that topiramate does have benefit potentially with migraine headaches. Oftentimes the main logistical consideration comes down to cost and insurance coverage limitations. Unfortunately, there are more often than not insurance-related issues with having these medications covered. So for the popular injectables, the GLP-1s, they can be very costly without insurance coverage, anywhere from $349 to $499 per month. And that's using cost savings options. Oral options in general tend to be more so around $15 to $70 per month, also a lot of variation there. One example of an over-the-counter medication is orlistat. It does not require a prescription. So some of the general ideas with pharmacological treatments that apply. In big picture, the average weight loss tends to be anywhere from 5 to 21%. That said, there are some individuals that respond more so than expected. These are hyper responders, and others less so, hypo responders. We want to make sure that the option that we select is efficacious, so we'd want to see at least a 5% body weight loss achieved after 12 to 16 weeks of treatment on the maximum tolerated dose. If there is not a weight benefit, then we should consider an alternate treatment option. Most people will tend to regain weight if the medication is stopped. So more often than not, these medications then should be used long-term in the treatment. Otherwise, there is the weight regain that can happen. So to delve into the individual treatment options to a higher degree, first we'll start off with phentermine. Phentermine is a sympathomimetic amine. It is a scheduled stimulant with FDA approval for short-term use of 12 weeks. Some of the major side effects include headache, blood pressure, pulse elevation, overstimulation, tremor, dry mouth, restlessness, constipation, insomnia. You would not use phentermine if a patient has uncontrolled hypertension, uncontrolled hyperthyroidism, seizure disorder, cardiovascular disease, among other conditions. The reported weight loss can be anywhere from 5 to 12% after 3 to 6 month treatment course. Next, we'll talk about phentermine topiramate. So a lot of the considerations for this medication are as above with phentermine, but adding in the considerations that come along with topiramate. As we know, topiramate is used in the treatment of seizures and migraine headaches. It is also a scheduled medication. So some of the side effects that are added here would be related to the topiramate component. Topiramate may cause paresthesias, that's the numbness or tingling sensation in the extremity. It can cause dizziness, dysgeusia, which is an abnormal taste. Contraindications are similar, with the added thought that topiramate is teratogenic. So if a patient is of reproductive potential, you want to make sure that there are regular pregnancy tests being done on this medication. The weight loss tends to be 10% of body weight. Next, we'll talk about naltrexone bupropion. This is a combination of naltrexone, which is an opioid antagonist used for addiction, bupropion, which is used for treatment of depression, smoking cessation. Some of the major side effects are nausea, constipation, headache, among others. You would not use if a patient has uncontrolled hypertension, seizure disorder. The average reported weight loss is between 5 and 6%. For orlistat, that is a gastrointestinal lipase inhibitor that impairs digestion of dietary fats. As we saw, it's available over the counter at low doses. Major side effects are that it can cause oily stools, and flatus, especially if a patient consumes a fatty meal. It can promote gallstones and kidney stone formation, and it can impair the absorption of fat-soluble vitamins. So you'd avoid this in patients who have chronic malabsorption syndromes and cholestasis. Reported weight loss is the lowest at roughly 5% in patients who can actually stay on the medication. The foul-smelling stools tends to be a very limiting factor for many individuals. Next, we'll talk about the GLP-1s. These are liraglutide, semaglutide, and tirzepatide, knowing that tirzepatide has an additional agonist effect at glucose-dependent insulinotropic peptide receptor. Major side effects tend to be gastrointestinal related, nausea, vomiting, bloating, fullness, diarrhea, constipation. Contraindications will be noted in the next slide since they are fairly lengthy. The least potent is liraglutide with 7 to 8% of body weight loss. Semaglutide next, it has 15 to 16% body weight loss. Tirzepatide is the most potent at 22 to 23% weight loss. So some of the contraindications, you would not use this medication if a patient has personal or familial history of medullary thyroid cancer or type 2 multiple endocrine neoplasia syndrome. It has been shown in rat and mouse studies that GLP-1 induces tumors, these thyroid C-cell tumors, and it is unknown if there's a similar risk in human subjects. You would also not use this medication if a patient has personal history of pancreatitis that's unexplained. So some of the special considerations that come along with these medications, you want to be mindful that you discontinue the medication if a patient has suspected pancreatitis, gallbladder disease, or suicidal behaviors. You'd be very cautious in your patients with type 2 diabetes that are treated with insulin or sulfonylureas, as adding a GLP-1 receptor agonist in this setting may promote hypoglycemia. For your patient with pre-existing diabetic retinopathy, you'd also want to be cautious with semaglutide and tirzepatide, as there are rare reports of worsening of retinopathy. For the best tolerated option, that would be tirzepatide. For your patients with gastroparesis, you'd be cautious with this medication class. So some of the high yield concepts that I wanted to go over that may appear on the wards and on the boards. The first question I have to you: what is the current most effective treatment to treat obesity and related comorbidities, including type 2 diabetes mellitus? That is your Roux-en-Y gastric bypass, where we saw the excess body weight loss of 60 to 75% on average. If you have a patient with a history of gastric bypass that's presenting with ataxia and new cardiomyopathy, what is the most likely explanation? So this is getting at wet beriberi syndrome. That is your vitamin B1 deficiency or thiamine. So likely the patient is being non-compliant with their supplements post-surgery. And thirdly, what would be your preferred pharmacotherapy for a patient who has obesity as well as type 2 diabetes mellitus? That would be a GLP-1 receptor agonist. So I know that this is a very big topic, and we were not able to cover all the nuances when it comes along with surgery and medications. If you want more resources, I have included some below. Thank you for your attention.